I'm Anissa Mitchell with PMD Alliance, and today we're having another part of our Young Onset PD series I'm in. This is in partnership with Supernus, and we've been covering a variety of different topics related to young onset Parkinson's disease experience. And today we're actually going to be talking about emergency room and hospitalization, something that many people who are younger don't necessarily plan for. It's not something that they expect unless they have other medical conditions, but generally are just living life and may or may not be prepared for that specific incident to occur. And so Heather Kennedy, whom many of you probably know, is going to be sharing a bit of her experience today. And you all probably know her very well, but I will go ahead and do a bit of a more formal introduction to her. Heather is an advocate and an artist. She is founder of Kathleen Kiddo, which is an advocacy site offering resources and connection for people with Parkinson's. She does writing and vlogs, and you can see in her background, she does beautiful artwork. She's known for her very unique and artistic ways of sharing of her life experience with Parkinson's and increasing disability as she ages, as we all do, and what that's like aging even with Parkinson's, and something that she didn't necessarily expect or prepare for, and which is our topic today. And I know a lot of you are part of the PD Avengers and the Parkinson's Secrets with Ray Dorsey and not all of them, Dr. Oken. And they actually had a quote or a statement published back in July of this year that each year approximately 1/3 of people with Parkinson's will visit the emergency department or will be admitted to the hospital. And honestly, I think that the majority of us probably really don't think about it much and may or may not be prepared. So I want to kick this off to Heather. First, I want to ask you, and before I do, this is a conversation style program today. So it's interactive. Heather's going to be sharing her experience. We're going to be asking questions. So please put your questions in the chat. We will intertwine those into the discussion today. It is literally a conversation with all of us, with Heather sharing her experience. And Heather, I want you first to kind of talk about, your experience going into the emergency room, sort of a cautionary tale for all of us to be prepared. And then you had told me before that we're all going to have a crisis. It's just a matter of when. So I would love it if you would kick us off by sharing what your experience was, what happened to you.
Thank you. Thank you so much. It's really great to be here. I wanted to mention before I start, thank you for the PMD Alliance. You've made changes to thousands of lives, millions of lives, probably. Who knows how many people that you've affected with your work. I use your meeting groups often. I go to your support groups, and I appreciate your website being so easy to navigate. Also, there are people here, including my family and one of my best friends who actually saved my life. So it takes a village. I'm only here because I prayed to get out of there and because I had an advocate with me in the emergency department. I would not have gotten through that night without Kelly Travis. And also Petra Luber, who came in as a doctor and demanded that I get another scan. So let's just start there. Sorry, I get a little emotional when I say that part because I'm so incredibly grateful. When we are incapacitated, we go to the emergency department for help as a last resort. It should always be the last resort. And before I start, once again, I want to mention there are nurses and emergency room personnel, emergency department personnel who work very hard. They don't have the compassion fatigue. They do care. There are also those who don't want to be there for whatever reason, and they have a lot of compassion fatigue, which is understandable. I can see all sides of this. Since COVID, they're pressed. We have an opioid crisis. We have people coming in for narcotics. Oftentimes, our symptoms are confused for other things like DTs. And we do know that addiction's misunderstood, and often it gets punished. So I entered the emergency room by way of my friend Kelly, who found me on my bathroom floor, semi-conscious after lying there for a long time. It had been 3 years since my spinal pain began, and I didn't know what it was. I didn't know that my spine was off. I didn't know that my 2, 3, 4 were slipped. I didn't know that I had cysts on my spine. All I knew is that my leg was numb, my neck was numb, and I was in more pain than the blocked kidney, the broken arm, the shoulder reconstruction. I was in more pain than the brain surgery. I knew that it was a pain I had never experienced before, and I was begging to die. This was around 3 a.m. I get to the emergency department by way of my ex and Kelly. And as we enter, the intake is the most important part. And that's where the problems begin. The communication and intake is so imperative for people with neurological problems. We must repeat, I have dystonia and I have Parkinson's disease. I've had this for probably 20 years and I need to have my meds. They didn't know that. I had my wear and care kit. They weren't interested. It's not on your chart. They don't have time. They're busy people. I really wish I had had this tag with me. I found a company on Etsy, which has a tag which you can place all your medical information on. Now, once again, they may not look at that. I may not be wearing it, but just in case, they also have these tags that can clip onto your watch. If you have a smartwatch, in case you fall, which I highly recommend, they have clips, same company, that can go right onto your watch. So you always have some kind of identification with you. There are also different things you can carry in your wallet, such as medical alerts and things like that. So I highly recommend that you do something like that. It couldn't hurt. And the Aware and Care does a great job, but once again, my emergency department didn't want it. So once I got into the place where they're doing the intake, the person who did my intake presumed some things. I don't know what, I can't read their mind, but they wrote some things on my chart that I was able to read later that suggested I was seeking pain meds or something, who knows what. I don't think they really knew, but it's not their job to diagnose us. That's not their job. They're just trying to triage. So we get in there. I'm also reading the comments. I'm acting a little distracted here. Thank you. We get in
And
there.
I got you for that. So I will insert things, but yes.
Thank you so much. And I'm lying there for quite a while. It wasn't until about 9:30-ish, I believe, that a doctor who just happened to be on his rounds came in. They never called a neurologist because we don't have many available probably. And it was between, those hours. So I didn't get care basically until like 1 o'clock that afternoon. But anyway, the doctor comes in at 9:30, tells me to stop crying after I've been begging all night for something. I had been soiling myself. I couldn't get my meds. They wouldn't allow me to take any water. I wasn't hooked up to an IV or anything. They were just monitoring me with a little finger thing and something else. I had my pants down to my knees. My new acquaintance, who was the doctor who came in to help me, and my friend Kelly had to clean me up several times. They just wrote in my chart during all those hours, incontinence, which is a sign of a spinal injury or problem. And that's all they wrote. That was the charge nurse's only note. Same charge nurse I had the other 2 times I was in there in the previous 6 months to 12 months. Same charge nurse who did the same thing and just released me with one pill of some sort. Like she said, here's what you wanted. And I'm looking at her like, what? And it didn't occur to me that they're so tired there of people coming in with DTs or whatever it is that's going on there. I could never be an emergency department person. So I'm not necessarily judging them, but they did misdiagnose and mischaracterize me. So what I'm saying is during your intake, it is imperative. And if you can, do not go to emergency rooms alone, ever. Always have someone. If I hadn't had Kelly with me, I don't think I would be here because my leg would have been entirely numb, possibly useless. I could have been paralyzed from the waist down pretty easily. I needed emergency spinal surgery. And I didn't want narcotics or opioids. Those slowed the motility of our gut. Then we can't take our medications and we're frozen. We can't move. That's what happens to me with my Parkinson's. My gut motility is very important to me. The last thing I want is a painkiller to slow that down. But once again, when you're begging for help like I was, and just begging. I was praying and begging. I said, God, if you get me out of here, I promise to use everything I've got to be the best advocate for others who don't have a voice. So
Heather, can I ask you a little bit about that intake experience and just the importance of one, not, and thank you, Eric, not going alone. So the importance of not expecting yourself to be your advocate, but having an advocate and then a backup and then a backup.
Oh yeah.
So I want to unpack that first, and then I want to talk a little bit about, the fact that you're obviously not at your optimum at that point because you're in the emergency room, and in pain or whatever the experience is. Maybe you're not even able to speak because you were in an accident or something. So whatever has caused you to be in the emergency room, you're not really capable of articulating what your needs are.
Right,
and so that advocate is so important. So let's talk a little bit about that, because I think for many people, we don't necessarily think about that. Like, we have one person maybe assigned, but if they're not available for some reason, what is our backup plan? So let's talk about that a little bit.
Yeah, because the person who was on all my paperwork and had access to all the numbers in the phone tree, knew who to call, when and how and what, including my neurologist, was not available. That was a huge misstep on my part. That person knows my children. That person was supposed to call the kid. That person couldn't, she was incapacitated. Of course, this timing was awful because I didn't have a backup for them. They are irreplaceable to me. And so my friend who was just visiting, who was the person who was with me in the ED, didn't have access to all the information and couldn't get the right information from that person. So that was why you need a backup plan for your backup plan. You need a plan A, B, C, D, E, F, G. You need to go all the way through the alphabet if you can. Overcompensate. Prepare for this like your life depends upon it, because it does. And this is not just for people with Parkinson's. This is for anyone. Think of people who are aging or who have dementia, Alzheimer's, mental health issues. The emergency departments are not equipped for any of this. This is a huge hole in our service. I mean, if you think about it, we have late stage capitalism, free market, for-profit medical system. It's kind of a disaster, and it affects everyone. So it's affecting the people in the emergency room, just like it's affecting us, only we're clashing like rats fighting over the scraps. We need to work together. It takes a whole system. Eric, who's from Gray Strong, is here today, and I would like him, Eric Aquino, to put some things into the chat about how you can get involved, because we're going to be going through patient panels nationally and hopefully internationally. There's a Parkinson's patient who runs an emergency room in the UK. His name is Johnny. We'll be talking with him to compare notes, to see how the different nations are equipped or not. So that's going to be interesting too.
And Heather, somebody wants to know what you have on your Parkinson's tag, on your necklace.
Mine says that I need my medications every 2 hours, that I have celiac disease, so that I'm not given anything with wheat, because then I will vomit. That would be kind of a dangerous situation for trying to take meds. It also says that I have a person to call here, and right now I think I have my son's number on there. It also says that I have a DBS implant, which is kind of important information, and not to get too risque here for you, but this would be a clue to them, but they don't know what this is. In fact, I heard the emergency room personnel, and I couldn't talk, say, does she have a heart monitor? What is that? And I thought, look at my chart. I couldn't believe it. And my friend had to sort of tell them what was going on. And if she hadn't been there, once again, I was just sobbing uncontrollably. I was doing the ugly cry, like 9 hours or so. It felt like
you were in the emergency room for how long?
Approximately, let me think. The first attending doctor came through around 9:30 a.m. He's the one who told me to shut up and stop crying. And the other person said, don't cry over spilled milk. We're here now. They had no idea that what I'd been through that night. Anyway, so I want to say it was, let's see, 3 to 9:30. I didn't see anybody except a couple. The first nurse who took me was great, but she left and they switched shifts. And the next ones just disappeared. They were not there. I don't know what happened. I checked all the blotters. Nothing big was going on. But I've spoken to some people since then. I've heard a lot of stories. My situation is not unique. What happened to me is not an anomaly. This is extremely common. There are people right now in this group who've suffered through things you can't even imagine. One of them was taking someone to school, and she was in another state and got into this emergency situation where she had to be taken by ambulance to a hospital that she was not a part of. And they have different rules there. And they assumed by taking the bag of medications, which are often not organized because our hands don't work, she couldn't put her medications back into the little containers. So it looked like a bag of pills. And when the doctor pulled that out, she goes, I have your drugs here. Suspicion immediately because of all these opioid crises and everything. They wouldn't let her pee alone. They're very suspicious, and they wouldn't give her anything to drink for hours and hours. She couldn't take any of her meds because they took her bag. I mean, this is not kind care. And we cannot teach compassion. We cannot demand it. We can only prepare. You know, there are people in that room that are going to have their biases, but they shouldn't be judging that way. And even if we were addicted, why are people with addictions being treated like they are monsters? That's my question. Gabor Mate is very clear about addiction being a disease.
Absolutely. And so, you know, you're correct that it's so many variables that can impact the experience. And that is why it's so important to, you know, have your advocate. And, you know, someone made a comment about, you know, it's certainly not realistic for people to be able to convey, I have a DBS and I need my medications on time. These are the medications that I need. Please do not give me any dopamine blocking medications, which are very common in the emergency room. And that's why it's so important to not only identify your first, your second, and potentially your third person, but a couple of things with that. One is discuss with those people all of the things they need to know to advocate for you. Make sure they're fully aware. And two, and thank you, Eric, because I was going to mention that, put them in your emergency as emergency contact, your IC, your ICE, your in case of emergency contacts in your phone, not just the one, but your second or your third, because that's something that the first responders can get to. That's where they're going to look. Anything they really don't, but hopefully they will. But that way, especially also if you have it listed on some form of a tag or something, these are, I mean, they're not foolproof, right? But they give you an opportunity to cue people to, I do have people that can speak on my behalf. Because there are all of those things that you're trying to navigate.
I'd like to tell a little bit of another story too, speaking of navigation. There's someone else here who was strapped to a gurney for probably, I want to say it was 19 hours or something outrageous, and had so many health issues that she ended up frozen, and she had a stroke and she couldn't speak and she was calling for help, and they quite literally forgot her. It makes me sort of shake with rage, not just Parkinson's. So, and you know, these are problems that happen all the time. And this is a highly functioning, highly educated, great healthcare. She just didn't have anybody with her. And we know that we lose our voice. So it is so, I mean, we have Kat Hill here who was, you know, she caught babies for her vocation. She was a midwife and she worked in the hospital as a nurse, and she's very highly trained. And she's heard stories too about that section. But what we're just focusing on, this emergency department training. Again, we can't teach the compassion part, but we can address the compassion fatigue, and we can train them to identify quickly neurologic diseases such as MS. I have a very good friend with MS who is unable to move from the neck down. How is she going to signal to them if her voice goes out? What if she has, you know, a crippling migraine and cannot communicate properly? What then? And be careful too with your DNR. People can misunderstand being frozen for something else. So check your paperwork.
That's a very good topic of, you know, do you have your paperwork and do you even know what you need? And so I know you've learned some things from this. And I know Kat, you know, being a healthcare provider herself, does have some some insights. I don't know if you're open to her sharing a little bit and engaging in this conversation. For the majority of you, just because of time and everything, we're going to encourage you to write your comments or questions in the chat. But Kat has been part of this Young Onset series, and as another person, living with Parkinson's and also a healthcare provider, I think it would add to this conversation, because there's only so much we can do, and we need to continue to advocate for change in our healthcare system. But the one thing you do have control over is, preparing and finding ways to help reduce
Right.
to the degree you can some of those things.
I would also mention Esther, who's worked in healthcare, and I would also mention Eric, who has been a first responder and knows all the lingo. And so there are several people here who are, I would call them, they know what they're doing to help us. So.
Kat, did you? Okay.
I just wanted to chime in just for one quick second. And Heather, hi, love. I appreciate the perspective and the story, because I think it's really important. And I think that our assumptions as a patient going to a hospital for help, we are assuming that the people on the other end are experts, and experts do exist in hospitals. So I'm not telling you that they don't, but not everybody in global acute care management, not first responders, not folks necessarily in the emergency room, not necessarily everybody at urgent care understands Parkinson's and neurologic diseases. And so I think it's important that our advocates understand it better, and that we advocate that those resources get on board quickly. We need to involve neurology in the conversation as soon as possible. We need to provide those resources on our emergency tags and for those people that are advocating for us, so that the neurology voice is represented. And neurologists should know more about Parkinson's disease. And the shoulds, we can should all over ourselves, right?
Mm-hmm.
And we can do better. We should do better. We need to do better. And I'm not at all disputing or trying to defend the healthcare team that took care of Heather.
Right.
But I do want to say that sometimes our expectations aren't met in the emergency room, because we have an expectation that everybody has a certain knowledge base. And unfortunately, they don't, and they can't be experts in everything. And that'll be my 2 cents. And now I'm going to hush.
Thank you so much, Kat. We've worked together on the World Parkinson's Congress and many things, so I know that her knowledge. Also, I would mention that there are people who are reasonable in such situations and who are not. There are people who overreact and who make things worse. And I try to stay focused. There's a great book called Random Acts of Medicine, which I will place later. I think we could probably look it up. It's published by Doubleday, I think. And it talks about some nightmares that happen with people who have different diseases, who are rarer diseases, or who don't show. And that's tough. And they're not even on their chart maybe yet. Who knows? Maybe they're not diagnosed. And I see we have a raised hand too. Miguel.
Yeah, and I don't know if Miguel is able to drop it in the chat or not. I know there's a lot of people wanting to know, how did you get through this? What would it, first of all, like, what was the outcome of this visit you had? And then I guess then follow up to that, I would like to know, what did this surface for you that you needed to do differently or change, just in terms of your preparation? But then of course we've got that larger conversation of how do we educate the community, what systems need to be changed or put into place.
I can tell you exactly where I went wrong. That's easy. I didn't communicate properly with my ICE person. I didn't have a backup. I didn't have a backup for my backup. I didn't communicate effectively with my family. Like if they had called my mother, my closest person, right? She wouldn't have been able to tell them what medications I take. She lives in New York. I'm in California. Why doesn't she know that? Why, that's something that we need to communicate better. We can just send people lists, whether they want them or not. They just put them aside in case of an emergency. It's imperative that we do this. Also, where I went wrong, the first 2 times I went, I didn't have anybody with me. And they just left me there in a room for 10 hours thinking that I needed to dry out, I guess. I don't know what they thought. They handed me a Benadryl once before I left. And then I asked the attending doctor, I said, do you guys learn about Parkinson's? I don't mean to be, insulting. I know that you're an MD. I respect you, but it seems like you don't know about Parkinson's. He said, we don't have to. We only see a couple of you every other month. And he walked off. He said, excuse me, took a call and walked off. So, what are you going to do? We're going to train. That's what we're going to do. We're going to train. We're going to communicate better. We're going to teach people how to communicate with doctors. Don't flood them with your feelings like I do. Just the facts, ma'am. When you walk in for that intake, you say, my leg is numb. I have incontinence. I have crippling pain here, here, and here. I need help immediately. Someone has to say that. So thank God Kelly was there. And Kelly was the best. She sat with me through all of it. Never missed a minute. Took care of my home in my absence. Jumped right in, took off work for 2 or 3 weeks. Amazing. I'm alive because of this village here. So many people here helped me. Some people don't have that.
Absolutely. And can I go back to, because I know I said Michael had his, or Miguel, sorry, had his hand raised.
Oh, I forgot to tell you too. I forgot to tell you the outcome was that I had spinal surgery and I can walk now without pain.
That is good.
So
Thank
I'm not.
God. Thank God.
There's no litigation happening. I'm on the patient panels for the same hospital now. I don't want to go after the hospital. I want to go after the change. I want my voice to be heard. And they hooked me enough with my ego. So I said, oh, I'll be on the patient panels. No lawyers for you.
I love that positive approach to
no
managing
idea.
that.
They have no idea what they're in for now.
So Miguel says he has a friend who works as a cardiac ICU nurse who says that drug addicts and those thought to be or appear to be are despised and seen as stealers of time and effort that could be better spent on other patients. So those patients shunned and given minimal attention. It's, an unspoken policy. And I think that is exactly what you were getting at. Like, assumptions are made because they see it so frequently. And so it's a quick assessment. It's again, emergency is all about triage. You need people, maybe that's where your skill focus is on preparing the people in triage, not thinking like big picture, the entire, team in the ED, but who's your triage people and what do they know? And then we had another comment, the system has to change. As a former hospital admin, I can tell you that we played whack-a-mole forever until we work together to change things. And I think that's what you're sort of doing now that you've been through this experience on this board.
Yes, the emergency severity index, I just brought it up. It's a bunch of colors. If that charge nurse brings you down a color, no offense, excuse my language, but you're screwed. There is nothing you can do to move that color back up. You can beg and scream all you like. So why are they given so much power if they're not trained? We just want to train them. We don't want to shame them. They're working hard. We're on the same team, so yeah. And Miguel makes a very good point. If you're seen as a stealer of their resources, of course they're going to resent you immediately. They don't have to know you. I don't know. Was it my tats? I don't know what it was. Was it my behavior? Sometimes my mouth goes off when I'm in these situations. My body's already dead and gone. So they thought that I was okay and just popping off and wasting their resources. Who knows? It doesn't matter what they thought. We have to use the serenity prayer here like we do in all situations. What can I do? What can I do to make this better for everyone? My neighbors with a deficit of housing. They get in there all the time and they think that they just want a blanket and warm place and they just kind of kick them back out. So the resources are lower. Yeah, I don't know if that answered anything, but I was just thinking that while we were talking.
Well, I don't know that we necessarily expect or think that we're going to come away with a solution to the issue. I think it's just having the conversation around the fact that it's challenging for all people with Parkinson's to go into the emergency room and hospitalization for lots of reasons, not getting their medication on time, and then inappropriate use of other medications. That's one piece of it. When you're younger, they may be less prepared. And you said there may be, an age bias of who has Parkinson's. And so
Right.
therefore they're looking at you not as a potential person with a neurological condition, but somebody who might be there for other reasons that then they have, maybe a predisposition to not appreciate, so it causes challenges. So that is talking about what can we do? I love that, to stay out of the emergency room. And then what do we do if we have to go into the emergency room? So I think those are two different, but yet very connected things.
The reason why I want to push this charge through too is very simple. I am a person who has a lot of privileges. I have great health care. I'm highly informed. I am a person who enjoys privileges that not everybody has. I live in a bougie area. This is an award-winning hospital this happened in. These people are not evil. They're not monsters. They just made a mistake because they're not trained. We just want to get back in there and have a conversation with them. It's not about like getting somebody out of there and firing them and causing them trouble and, getting them back. It's more like, hey, hi, it's nice to meet you now that I'm on my feet. Can we have a conversation? Can we do this better next time so that people don't have to suffer and it's easier for everyone? Think of the possibilities if we ended up working together. Let's reach across that board. Maybe I'm an idealist, but I believe this can happen. I love nurses. I go see the nurses on the 4th floor of this hospital every time I get a chance. I give them coupons for different things and like places to eat around here. And I hug them and I give them candy and I give them pizza. They're wonderful. They rock. They're on their feet all day doing, 12-hour shifts. God bless them. However, everybody needs more training because while I was in the hospital, I had to work with the pharmacist who was amazing to reconfigure my med sketch. The med schedule doesn't get to us because we need to look at this like we're diabetics, that the timing is everything. Can you imagine if we shifted Parkinson's from something that doesn't really have the time considerations to something that it matters exponentially, like you have to have your meds on time or you go into the fit, and then it would save them all that bell ringing. You can ring my bell is not the nurse's favorite song. I won't ring your bell if I get my meds on time. Win-win.
I think what you just said is sort of a key point. It's about changing the concept of Parkinson's to a timing issue. We do it with people coming into the emergency room with a stroke or a heart attack. It is a timing issue for people who have diabetes. It should be a timing issue for people with Parkinson's too.
Yes. And it's up to us.
Protocol. Yes, Eric,
Yes.
A protocol issue.
Eric knows too about the charting system. Eric has worked already in the Epic system, and I petitioned them to change my chart, which took about 90 days. It's not really changed yet. I was questioning the way that things were listed. It said like oral surgery. That was in 1985. I had my wisdom teeth removed. Why is that the first thing they see? So I went in and I talked to the people that do the charting. Very hard to change your charting. I encourage everyone to go into the Epic system or the My Chart system in America. I don't know what they have in other places. Read all the notes that have been listed about you by your doctors. You'd be surprised. And I'm not saying it would be bad things. I'm saying that it gives you a lot of information. Look who does the best charting. Which one of your doctors does the best charting? Learn from them.
And do you feel like knowing some of the lingo is helpful too?
Absolutely, which is why I talk constantly to people that are in the system. The firefighter that I called before I got on this call, they told me point blank, I have dropped people off in different emergency departments all over this area, and I've been terrified for their lives. There was one person who did not speak English as a first language, was semi-conscious and needed emergency care in a very specific way. And he kept saying to the intake person, and some intake persons were very receptive. Others were like, yeah, we got this, get out of here. And then his team was pulled away for a fire or something else. And he never got to finish telling her. That person did not make it. Like, she felt terrible. Like these things happen all the time. It's just misinformation. It's literally just miscommunication and mischaracterization, which is uncomfortable and hurts, and now is deadly.
And that's an important thing, that bringing up the English not being a primary language, and needing that advocates, plural, just because, you know, if there is a language barrier, you already are dealing with a challenging system, and then you add in, you know, a language barrier, how much more of a problem that can create.
Yes.
You know,
I ended up hiring a professional advocate, like locally, to communicate for me to places that, like, for example, we didn't have an HOA in the condo where I live. And I would call the management company and they'd be like, I saw you walking before, so what if the elevator's out? He'll call them and explain, like, dude, ADA rules, like, what are you doing? So they have put these beautiful stickers up all over my building now. They have a nice little person sitting in a wheelchair. That was their response to me. Thanks, management company. So what they don't know is that as an advocate, I never shut up. Because it's not about me. It's about basically representing what I know about YOPD. So.
And Sabella said interpretation is a right, absolutely. But if the person comes in alone and they're not responsive, or only semi, that is why we're saying definitely have somebody that can come in and be your voice, because you can't always speak for yourself. Even in the best of, you know, situations, you may not be able to advocate for yourself when you're not well.
Absolutely.
I love this conversation. Yes, and it's true. It can take time to find the translator. So, and time can be, you know, extremely important when you enter an emergency room.
We have someone here who's having a birthday who came to my talk on his birthday. I just want to say happy birthday. I'm not even going to say your name, but you can just wave at the camera. You're looking good. And I must say too, that I heard another horror story. It was an older gentleman who was dropped off by a friend who found him in his apartment. And once he got in there, they wouldn't listen to him. They took him to a mental institution, dropped him off where he woke up with someone's hands around his neck, because the person who was in his same room went through these delusions and psychosis. So once again, being mischaracterized as painful out in the real world, once you get in there, it's dangerous. So, you know, and being strapped to a gurney, not being able to move, we already can't move. That's a nightmare for us. I can't even use one of those gravity blankets without panicking. What can we do? And I want to mention too, real quick, the PHP or the IOP, the two things given for people with addiction, needs to be more streamlined. Get them out of there quickly for some help if they are detoxing. Treat people with addictions with a little more humanity, please. I beg of thee. Because now I know how they're treated. I only had a little tiny glimpse. At least that's what I'm guessing. Who knows? Once again, this is all hyperbole. I'm not sure why they kept me there 3 times for so long. I'm sure there's a my advocate Kelly has written extensively about this. And then that's why I was invited to these patient boards. I think the squeaky wheel does get the oil in this case. And I have called the ADA about a number of things, but not that visit. And we have very strong rules in place. We also have training in place. If we would just use it, you know?
Yeah, and Esther said, who's talking to HCA and Tenet and all the others? So if you can be an advocate and get on a board, get involved with advocacy organizations like Michael J. Fox, you know, that's doing a lot of work around this, as well as I know Parkinson's Foundation's doing, you know, work. So anything that you can do to be the voice to help change the standards of care, and, you know, how people with Parkinson's, well, all people, but we're talking specifically Parkinson's and, you know, related type neurologic diseases. How can we improve the care, you know, in the system? And then what can we do individually to help ourselves? One is to do everything you can to stay out of the emergency room. I know somebody commented about that earlier. But two, there are just times that we can't avoid it. If you're in an accident or something and you end up there, what do you say were your key takeaways, Heather, that you would recommend people besides the ICE, knowing who your advocates are? What are some things that you either are glad you had in place, but maybe didn't utilize or need to have in place so that you could at least improve the potential outcome?
Make sure someone's with you. I know that's not possible at all times. You might be on vacation and someone else finds you. Try to make sure someone's with you. Whoever it is, make sure they stay with you. I don't care if it's a stranger who found you or what. Do not go in there alone. You need a mouthpiece if you are compromised. And in trauma, none of us are skillful with communication. I'm not even skillful when things are going smoothly. I'm liable to say something that's incendiary or wrong, or I'll put my foot in my mouth. Remember, we're all human. So are the people that we are arriving to in the emergency department. Just as Kat said, these are human beings with their own biases that we know nothing about, with their own lives, with their own exhaustions. They've probably been there for 12 hours already. Maybe they're doing a double shift. Who knows what's going on? Maybe they haven't slept for ages. So we need to approach it as if we're already compromised and they know nothing. Not to lecture to them, but to say, hey, Parkinson's, Cinemet needed every 2 hours. I will go into dystonic fits. If I don't have my Parkinson's, you're going to see this. And this could look like a DT. I don't know what it looks like to people. Who knows? So we need to communicate that stuff. And then lastly, have your backup for your backup for your backup. And if you can, make sure you have the tags, the aware and care kit, sure. The things that are in your wallet, the double ice, like Eric mentioned. Eric has tons of tips at Gray Strong as well. And we'll be working at this constantly to develop this, because this system is not working.
Can I also add to your advocate? It is very helpful, especially if they're not a next of kin and they're not able to speak for yourself, to make it legal, and maybe appoint them as your healthcare surrogate or your power of attorney for healthcare, whatever your language is in your state, which gives them the legal right to speak on your behalf if you're incapacitated and able to speak.
Yes.
Because they may or may not listen, depending on, most of the time they're pretty good about that, I think, but this just gives them legal backing to make those. And yes, you can get it notarized. You can do those even outside of having an attorney. Most states have the forms where you either get it notarized or have two unrelated people witness it, but notarization is a little more official. Some people do like there are full advanced directives, living will, healthcare surrogate, power of attorney with an attorney. And there's another document called the 5 Wishes. It gets in a little bit deeper, but these are really important because they do give those people that you assign as your advocates actual power to speak.
Right.
And
another
get into your chart. You can have somebody be able to say, hey, she needs her meds or he needs his meds on time. That's one thing, but for them to be able to request copies of charts and things like that, like you need a legal document for that.
Hospitalists, physician's assistants. A physician's assistant actually also operated in a way that saved my life. He finally got to the emergency department as I was being transferred. And he said, why has she been in here so long? Where's the neurology aspect of this? And he said, she needs emergency spinal surgery. I've already charted her before. Why did you keep her here for so long? I could hear him talking and he was very calm. He wasn't yelling at the nurses or anything. He was just sort of saying, why is she still here? I don't understand. So they could have had an extra gurney and had some space had they gotten me out of there a little quicker too. Again, this is beneficial to all, not just the person in trouble. Another friend of mine, by the way, was taken in an ambulance one time and she went unconscious. And the ambulance drivers, when they delivered her, said to the people on intake, she was fighting us, unruly, terrible. They basically said that she gave them a hard time and was like lashing out and trying to grab them and stuff, like going into psychosis. And they strapped her down when she got there. And she doesn't remember any of this. She wasn't trying, she's like, she woke up strapped, unable to talk, without any meds, and had to lie there for hours in a state that's just not even her state. These are horrifying experiences. This is Jacob's ladder stuff. So now, if you do have a pre-existing condition, be careful what you do say to different people. Like, let's say that you're in the ER and you say, well, I'm in recovery. Immediately they're going to go ding. Might mean something different to you than it does to them. They might think, oh, recovery, oh, heroin addict. They might not realize you're talking about you might have an alcohol problem or something. Again, it's all perception. So just be careful how you do it. I would suggest getting copies of your chart notes. I would suggest looking carefully at your My Chart and making sure that you have your ducks in a row so that you can stay as healthy as possible. And there are no ducks in a row. I have squirrels and monkeys, but you know what I mean. Do as I say, not as I do. Get that paperwork ready and get a double set of it, have a backup. Just do it now. Don't wait. We're all human. We have bodies.
You made a comment earlier, and it's related to this, is like how powerful the words are and they can be misunderstood. Because when you went into the emergency room, you were in so much pain that you said something to the effect of, I just can't, I'm going to die, or I'd rather die than live with this pain. Oh, so let's just talk about, be careful with the language of things we say.
Well, I called
if you're alone, if you're alone.
I called around before. The days before I went to emergency room were excruciating, the 2 days. And I was calling different places, including my pain meds doctor that I had just hired because I didn't know what else to do. I called and I said, I want to die. This hurts so much. In fact, it was my friend who was on the phone saying she said she wants to die. It hurts so much. So it was like playing telephone, and they flagged me as suicidal and said, we can't talk to you anymore. This conversation's over, and they hung up. That's their protocol. Suicidal, go to the emergency room. How is the emergency room or the emergency department equipped for someone who's feeling suicidal anyway? That is the last place you need to be. And by the way, I called the suicide hotline to see what would happen, just as on a note. They put me on hold. You can't make this stuff up. That really happened. So what do people do? I don't know. I talked down here at the center, it's called the Trinity Center, with people who have a deficit of housing. I talked to their manager with my friend Kelly, and we asked about this. We said, what happens if they need medical care? Anybody, like anybody here. It's tough. And people kept talking about Obamacare. That was really Mitt Romney's baby. I mean, there's so much stuff going, like medical care is a mess, but I have the best. So if this happened to me, it's gonna happen to anybody, you know? All kinds of biases. And once again, we cannot teach compassion. We cannot preach empathy. You know, I don't know how many people have it and they don't. The person who looked at me and told me to shut up and stop crying was surprising. I did not report that person to the medical board, but I did talk to the people at the hospital about it. I hope he gets reviewed. The person who said, don't cry over spilt milk, we're here now, was very callous. Did it hurt me? No, not really. Did I find it rude? Sure. After that many hours, could he have been a little nicer? Yeah, he took my blood. He took the urine sample. It was everything was clean, everything was good. But what if it wasn't? What if I did have drugs in my system? Would I have been treated even worse? Would I have gotten my spinal surgery? I don't know. My friend Kelly was there throughout. My friend Petra was there throughout, and they saved me by communicating for me. So it took two, and it took a village. Once again, there are people here that know exactly what I'm talking about. Their siblings were there, their children were there. And one of them had a little puff of marijuana. So like, well, there's THC in your, you know, and it was one of those states that doesn't have, you know, it open. You have THC in your urine. Yeah, it's better than the painkillers. And maybe it helps her with her digestion. I don't know what to say, but they immediately marked her as an addict. That's ridiculous and untrue and unfair and illegal. So what can we do? Lots of things. Keep communicating.
And you're doing it. Sounds like there's quite a few people, you know, with Eric and his Grace Strong, and many of you are, you know, jumping on that bandwagon of trying to be, you know, advocates for change. And that is so important. Having these kind of conversations, I mean, they're hard. They're hard to talk about. It's hard to hear people going through such challenging experiences, but it is important to surface what the issues are and what we collectively can do to move the needle on that. And then what do we individually do to kind of help minimize the negative impact on that. And so if there's any other comments or questions or things that we haven't yet covered, we still have about 10 more minutes in terms of, you know, a larger scale change or individually what you might want or need to know or discuss.
I want to mention the deficit of neurology students as well. We have less neurologists who are movement symptom disorder specialists than ever before. And nursing, who would want to be a nurse under these circumstances after COVID? It's tough. There aren't enough people training the nurses, I heard. The schools are having trouble finding people to train the nurses. You know, as the older generations retire, there's nobody to fill that gap. When I was little, people would say, what do you want to be when you grow up? And they'd say, I want to be a fireman or a policeman or a nurse. Look at these things now. It's tough. This is tough work. It is potentially, I mean, I know nurses who get spat at, who get punched, who get knocked sideways, who've had people follow them to their car. Like, it can be tough. So I see all sides. I just want to add that in. There's so many great comments.
And then Kat, you know, her comment about communicating with all of your providers is huge. It is important. And often it's on you to be that point of contact, making sure that everybody that you see knows what's going on with your treatments.
We recorded some of what happened to me too. Well, my friend did. There were recordings. It showed the clock and then my gurney and the clock. It was no one else's face, but it was some recordings of what people said, just so that we had access to the proof. It wasn't that we wanted to go after anybody. We wanted to know what happened because I was not really together. So, and you know, they're probably recording you in the room too. Just keep an eye on you to make sure that you're not falling off the gurney and so on and so forth. I never thought about that until now. Boy, oh boy, I shouldn't pick my nose on camera. But the questions and all these comments are great. Asking questions about calling coverage for, coverage is wild. I waited forever for this one medication because it had to be, you know, you had to check with your insurance about something. And it was a medication that would have made all the difference. That wouldn't have happened had I had that probably in the same way. So, you know, and
I just want to highlight that this is a really hard topic.
yeah.
And your experience was really difficult, and there's others that had a really difficult experience. And so it does seem negative in a lot of ways, and we don't want to focus on that. What we want to do is highlight an issue of what's going on, and we want to be change agents. So what are things that we can do? But most importantly, individually, we want you to understand, you know, some of the challenges you might encounter in an emergency room if you do have to go, or a hospital. And there's challenges in the system that are multifaceted. What as individuals can we do to make this a better outcome? So it is, and I think we've talked through that, you know, knowing your treatment well. You know, some people don't know even what medications are on, what the dosage is. So be aware, keep a list of your medications, have your advocates, you know, put them in your phone. If you need to make it legal and get advanced directives, do that. That's a positive thing. It can really eliminate a lot of issues. Get those things that say, hey, I have Parkinson's, I need my meds on time. And the Aware and Care kit they may not use the kit in terms of, you know, the medications, but there's those little tear off slips like, hey, you need to know this. There's meds on here that you should avoid, you know, have your advocate give those to them. Those are really helpful ways of communicating that. And have those people be aware of what is going on with you. So those communications of not only what your treatment needs are, but what what you do and do not want done to you.
And I also need to mention they're following very strict protocols. For example, these nurses are following a chart. When my father was dying, I said, give him morphine. She's like, that's not on his chart. And I said, I don't care what's on his chart. Go call the doctor. No, I didn't. I would have ended up in an orange jumpsuit, but I wanted to grab her and yank her over the thing. But then I realized, okay, she's getting paid $1.280 to take everybody's shit and to clean up everything. My dad had marks on his wrists and his legs. And we were like, why is he so banged up? He was fighting them every time they changed him because he was a modest person and he had dementia or Alzheimer's. I mean, the thing is, Lewy body is a very different thing. So anyway, he didn't understand. He's like, why are these people ripping my clothes off? So they had to strap him down. We thought he was being abused. But what are they supposed to do? He was fighting them, but he needed morphine. And they had to call the doctor and they couldn't get a hold of the doctor forever. It took forever for them to get him that. Just, we treat animals better sometimes, and
Well, Heather, I know I appreciate you sharing your experience and all of the comments, and, experiences that other people have had in the chat. It is really, like I said, it's a challenge, but I am just glad that we can have an honest, candid conversation about the issue and then what we can do. We don't want to leave you with just, here's the problem.
right.
No, here's the problem and what do we need to do or what can we do to change it? So hopefully those of you who are here today feel like there's been some, beneficial ideas offered to things that you can do and then individually, and then things that you can do, maybe consider doing collectively. And Heather, you already like paving the way for that. I know Eric is also on trying to be, advocates for the greater good.
Yes.
To make some changes in our system. And so I appreciate you so much. And I know everyone does.
This is going to sound really weird, but I'm really glad this happened to me. If it hadn't happened, I would not have been aware that this happens all the time. I've just been privileged enough to avoid it until now. Thank goodness I have Parkinson's and went through this. I can be of use now. I can help somebody. Hopefully somebody's listening and they'll realize that, someone in a position of power can make that happen. Thank you so much for allowing me to just share today. There's so many brilliant, wise people here who saved me. I just want to pay it forward.
Yeah. Well, our tradition, Heather, because you've been on this before. So I'm going to invite everybody to give you that wave. Actually, let's not do the wave. Let's do the heart because, you shared yours. And we share that love back. Like you said, we're a village, we're a tribe. So we share that back with you for sharing your experiences in your heart. And to all of you, I thank you so much for joining in on this conversation and allowing us to just get real with it. So hope all of you have a great day and we look forward to seeing you again.
Keep moving.
Thank you.